Thank you so much, Ashley.
All right. So, like I said before, I don't think Kyle really needs an introduction, but here's Dr. Kyle Rose. He recently graduated from, Moffitt, and now he is at Ochsner back in New Orleans. And I'll hand it over to him.
Thank you so much, Ashley and Graham. Dr. Adai and everyone in attendance, thank y'all so much for having me. I can't tell you how much I've missed you all and how great of an experience was to be there at TAF. And I wanted to show this picture. I was trying to find the picture with the 30 or 40 of us, which was truly an amazing capture. But before I even get started, I definitely had to say a thank you to our brothers and sisters at TAF, especially in Kumasi and Ghana. And especially to one of my mentors who you may or may not have met, Dr. Scott Gilbert, who's one of the faculty at Moffitt Cancer Center. He's a partner with Dr. Pak. But this is typically his lecture that he gives to the fellows, and we found it to be so useful and resourceful that I've incorporated a number of those slides here. So throughout this discussion, we're going to go over some of the complexity and morbidity associated with cystectomy, some of the reconstruction options, and the recovery, including the functional outcomes and the patient-reported outcomes. Cystectomy or taking out the bladder is a procedure that is usually performed in the U.S. at very high volume centers where we know complications are meant to be lowest. We have found that at Moffitt Cancer Center, we've had a very high volume of bladder surgeries. And for cystectomies, we take out anywhere between 200 to 250 per year. And the approach has changed slightly with the addition of robotic surgeons. But as you can see by the graph, the majority of these surgeries are performed open. And we can go into why that is. But overall, it's a surgery that takes anywhere between 3 to 6 hours. The patients stay in the hospital somewhere between 4 to 10 days. And it's typically fraught with complications. These surgeries are typically performed for patients, at least here in the US, that predominantly have bladder cancer. There are other non-cancerous reasons for which we take out the bladder and have to reconstruct the GU tract. The most common reason, though, is muscle invasive or advanced bladder cancer. We also have patients with non-muscle invasive bladder cancer that are either high risk or recurrent and not responding to BCG therapy or intravesical therapy, who are also best served by taking out their bladder. Some of the benign conditions for which we would excise the bladder and recreate or divert the GU tract, including a urogenic bladder, fistula, severe pelvic pain syndromes, and as well as some patients who have a colon cancer, a gynecologic cancer that's invading the bladder, or the excision of that tumor would require us to take the bladder out. And this is really one of the most humbling slides in this presentation. Despite this surgery being performed at extremely well-equipped and well-experienced centers in the US, the complication rate is extremely high when you consider the cystectomy and the conduit or the heel bladder. Complication rate ranges up to about 65% at the highest, and the bounce back rate, or the rate at which patients are readmitted to the hospital, is upwards of 30%. Most of the complications, and you see on the right side, looking at some of the major GU surgeries that are performed for cancer, cystectomy has the highest burden of readmission among all of these, and it's significantly different than those that are seen for other organs. The complications that we typically see are GI complications, failure to thrive, and infection. And what compounds this or makes this more difficult is that these patients who undergo cystectomy are typically older, they're more frail, and they have more medical comorbidities. And going back to the most common reason why these are performed, it's simply for muscle invasive bladder cancer. I mean, these patients in the US most commonly receive neoadjuvant chemotherapy or chemotherapy up front. So they remove a lot of their functional status, or their functional status worsen acutely preoperatively, which makes the postoperative care more difficult. I forgot to mention, I really would love to keep this an open forum. And if there are any questions that come up or any concerns, please don't hesitate to shout them out. But cystectomy and urinary diversion is typically performed around 10,000 cases per year here in the US. The vast majority of those are ileal conduits. But there are several concepts in this discussion that will come up that are both valuable in clinical practice as well as for exams such as boards or in-service exams. Again, ileal conduits are the most common type of diversion that is performed, but some surgeons estimate that up to 85% of patients who undergo cystectomy are actually candidates for continent diversions. Now, whether that's the right thing to use in these patients, that's very site specific, and we'll get into some of those settings. But the first attempt to divert the GU tract was reported in 1851 by John Simon. This continued and was primarily utilized for connecting the ureters to the sigmoid. And then Bricker popularized the ileal conduit using two independent connections from the ureters into the ileal conduit. Dr. Koch then established the principle of devascularization to create a low pressure system. And then finally, these techniques continue to evolve. The continent pouches or first continent bladders were created early in the 50s and 60s. And then the most modern types of bladders, which we will go into, were typically created in the mid to late 80s. That includes the Houtland and the Studer. But overall, the goal of these surgeries is to create an outlet for urine, which is obviously blood filtered into urine, to be able to expel that from our body. And there's multiple ways to do this, and we tend to categorize these as heterotopic, orthotopic conduits, and those in the continent. And we'll also go into the different organs used. And so not just necessarily by the functional status. Sorry, give me 1 second. There we go. Ashley made me the co-chief of this, so I have to click accept when people enter. So sorry for the interruption.
I've got you for now, Kyle.
Oh, thank you so much, Ashley. So most of these bladder types or reconstruction types, besides labeling them as continent or their location, can also be described by what organs are used. And for all functional purposes, we utilize the stomach, the two distal segments of the small intestine, the colon, the sigmoid, and the rectum, although the last two are much less commonly used contemporarily. The three most common, and the ones that we'll cover in the most detail, are the three listed below, which is the ileal conduit, the colon pouch, and the fetal bladder. So several segments are available and used frequently. We typically use the stomach, jejunum, ileum, and colon, but each of these has a specific drawback, which becomes very important not only for clinical practice, but for test-taking purposes and for exams. The first that we'll cover is the stomach, which is by far the least utilized, at least here in the US. I admittedly have never seen the stomach used for a GU surgery other than putting in a G-tube or a feeding tube. And one of the reasons is because it's associated with hypochloremic metabolic alkalosis. And overall, it's less permeable, which is a positive finding. It has a lower incidence of infections, and that's because of the acid that's secreted from the stomach into the GU tract. For testing purposes or for exams, I would always get these mixed up in terms of which ion was elevated or decreased in which bowel segment. And the way I always thought of this was, the stomach makes and excretes hydrochloric acid. We're losing acid, which produces an alkalosis, and we're losing the chloride associated with that acid, which produces the hypochloremia. The jejunum is typically not utilized as a part of the small bowel that's used for the GU tract. The reason is because that has some of the highest absorption rates of the urine, which in turn reveals or creates some of the most difficult chemical disturbances. If it's the only segment that is available to use, you should utilize the most distal portions or closest to the ileum as possible, even preferably more the proximal ileum. And we used to have this saying back in school, if we had a difficult time remembering one versus the other, say, remember one and the other one is the other one, meaning that all you needed to know was jejunum is the only bowel segment that resulted in hyperkalemia or elevated potassium. All the others resulted in low chloride and low potassium, not to chloride. When looking at the ileum and colon, these are the most commonly used organs for GU tract. Anatomically, they have the most consistent blood supply, they have adequate length, and they're usually fairly mobile. Overall, I think these are the most frequently utilized, and because of that, surgeons usually feel most efficient and most familiar using these. And important to know, again, that ileum and the colon share similar chemical changes in that the utilization or incorporation of them into the GU tract produces a hypochloremic, hypokalemic acidosis. Now, we've had some discussions when I was there at Cath about the different types of bowel diversions that we can use. And there are pros and cons to each. And again, I think it depends on the clinical setting in which you're using them. And we've had a discussion with Dr. Adai that, ileal conduits, while they are straightforward and they're the most commonly created here in the US, they're not necessarily the most sustainable because they do require an external pouch or external appliance that has to be changed every 3 or 4 days, which can be very difficult for some patients, especially with issues with access to care. So I won't go over the ileal conduit in too much depth, but typically this includes taking a 15 to 20 centimeter segment of bowel, dropping it below the reconnection of the bowel, closing the mesentery, and then the distal end of the conduit. Actually, can you guys see my pointer at all?
Yeah. Mm-hmm.
Perfect. The distal end of the conduit.
Yeah, we guys see.
Perfect. Thank you. Thank you. The distal end of the conduit here is brought up to the skin, usually through the rectus up into the right upper quadrant. The bowel is then everted and secured to the skin. And the reason it's everted is to prevent the spillage of urine directly onto the skin instead of rather going into a appliance bag. One particular challenge with this is that because the mesentery and the small bowel ileum is typically on the right side, the left urine needs to be tunneled under the sigmoid mesentery to the right side of the body. That's typically done through the avascular plane behind the sigmoid. There are some nuances here, but the overall goal is to not bag the nerves that are too close to the great vessels or too close to the common iliacs, and not to get too superficial, which is into the sigmoid mesentery and blood supply, which can cause very troublesome bleeding. A couple of very key points for ileal conduit to keep in mind is the orientation of the bowel and the conduit itself. The saying was always, when I was in med school, water under the bridge, to refer to the uterine arteries crossing over the top of the ureters. And we use the same saying when creating ileal conduit, meaning that when we take apart the bowel segments and we have a conduit, a ileal conduit segment, that drops below the bowel anastomosis, meaning that the bowel anastomosis here is on top. So the water, meaning the conduit, is under the bridge of the small bowel anastomosis. These two photos are showing issues that can occur when bringing that loop of ileal conduit up. On the left side, there's kinking or twisting of the mesentery ileal conduit, and you can see as compared to the large intestine, small intestine, that's pink and well perfused. This conduit looks congested, and it is compromised its blood flow, and the ureters have kinked as well. This can be catastrophic for the patients and can result in an intra-abdominal urine leak. And I mentioned before that we always close the mesentery of the small bowel. I'll go back a couple slides showing that the small bowel mesentery is always closed. And the reason is because we want to prevent an internal hernia or bowels coming through that area, which can then become incarcerated, ischemic, and then require a exploration. Moving on to some of the continent types of diversion that we'll cover. The two most common, or the most common ones that we'll cover, are the Houtman field bladder, the Studer, as well as the right colon pouch. And the idea being is that although urine is excreted into these pouches, it will be continent and stored and not visible or secreted into the external world unless the patient wishes so. And this was really for a right colon pouch or ileocecal pouch. This was first described in 1977 and in 1986. And the idea was to depugularize the ascending colon with a staple fixed intussuscepted nipple valve reconstruction of the ileocecal valve. And admittedly, I think this is a little more complicated than what we currently do, which is more of a second generation ileocecal pouches. And that includes a Indiana pouch, a Florida pouch, and a Miami pouch. The Indiana pouch is typically the most commonly used one, although this is in the general categorization the least common diversion methods that are used here in the US. The Indiana pouch uses a tapered terminal ileum that's plicated at the ileocecal valve for added continence and strength. The Florida pouch use a longer segment, including the ascending colon all the way up to the colonic flexure and possibly even parts of the transverse colon, which we have done at Moffitt. And overall, we'll see that there are several different changes and tweaks to the surgery for which obviously the surgeons had named that type of surgery after their institution. But some of the uncommon ones include the Penn and the UCLA. And there's just different alternatives here in different ways to secure the afferent limb and to add benefit to our continence. The idea here for continence, I'll kind of start on the bottom left image. And this is just showing an orthotopic native ureter coming into a bladder. And the idea being that with this natural tunneling that we have, as the bladder fills, that muscle and pressure from the bladder tends to kink or provide continence and prevent reflux of urine going back up into the kidney. And then on the top left, showing what that intussusception does. And this is typically, for example, in the right colon pouch. This is from the distal ileal segment or the afferent segment, being intussuscepted and providing pressure. And as that area fills, it increases the tension, meaning that the continence mechanism becomes more effective. There's other ways to do this. You can see on the top right side, this ileal segment is imbricated over either a wire or a catheter. And then here on the bottom right side, this is the technique that we typically utilize with staplers, is that we hug a indwelling catheter to take off more segment of the ileum to provide a smaller channel, which is at a lower risk for kinking. Moving on to the orthotopic bladders. There have been several that have been used historically. The ones that we will focus on are really the Studer and the Houghton, which are the most commonly used now. And truthfully, I think the most reproducible as well. But originally there was a Kingdom 1 and a Kingdom 2, which used the ileum, which was oriented horizontally and then brought down to the urethra, as shown here. And this is more of an S configuration, and this is it at completion. Excuse me. And then a mains pouch utilized the colon that was then brought down to the urethra. And then finally a T pouch, which was most commonly used at USC, using a serosely tunnel flat valve ileo-afferent limb. And finally, what we'll get into most commonly used here, what we're most used to using in the operating room is the Studer and the Houghton. And so the Studer is taking a segment of about 55 to 60 centimeters of the distal ileum, detubularizing it and utilizing the afferent limb to plug in the ureters. The detubularized segment is then sewed to each other so it forms a plate, and then it's folded back on itself to create a nice bowl. And you can see here, this is where we have unzipped the distal end. We have flattened it out and sewed a back line. And we're going to use these two markers as a halfway point. We're going to sew this segment up to here. And by doing that, we create a midline segment, and we now have a nice spherical heel bladder. So that's the Studer. What I wanted to show here, these are my notes from my fellowship from one of my attendees that performs a Studer. And I'd really recommend to any of the trainees or even the junior faculty in the room about how we keep notes and how we continue to improve our technique. I also think this really helps with mental reps about the different steps of the surgery, so that you can help prepare the trainees and prepare your team for how to best assist you. But again, this is showing how we select a distal 50 to 55 centimeters, about 20 centimeters off of the colon. And I also should apologize for my drawing. I'm not very good. My daughter, who's 4, routinely asks me to draw Disney princesses so that she will laugh at how bad they look. So I apologize if these aren't very good. But the idea is to create an afferent limb here. And you see the direction of peristalsis of the valve. The valve is oriented this way, so it appears to be more of a J. You sew this back line and you bring this up to fold the needle bladder. And then that leaves you with a left and a right suture line, which are then closed. So that's the Studer. And I think there are many benefits to performing a Studer. The most attractive reason from an oncologic standpoint is using this afferent limb, which allows you to bring the insertion of the ureters up higher away from the pelvis. So if the patient has prior radiation, or you think the patient may need down the line radiation, this will move the renal implant sites further up and possibly out of the field. Similarly, if they've had radiation in the past, you would be sizing the ureters, taking the ureters further up, where you're most likely to get a more healthy segment. The Houtman is a little more straightforward, albeit it requires more sewing because the suture lines are in this form of a W. You're selecting a very similar 55 to 60 centimeter segment and creating a W format. You detuberize the bowel, and you sew 3 back posterior plates, so 1, 2, 3. And by the end of that, you'll have 1 anterior plate, which is then sewed together. And so these are my notes from Dr. Gilbert, who originally created this PowerPoint presentation about how he typically sets this up. And you can see here in the form of a W, here, there's 1, 2, 3, 4 areas of folds with 3 suture lines. And the way he typically sets it up is with Babcock's, utilizing these 3 segments. So 1, 2, 3, those are the suture lines that get closed on the posterior side. And then the anterior side is fairly straightforward. Once we start the anterior closure of the suture line, we'll typically find an area that's most dependent, which we will use for the urethra, where we'll bring the new catheter in. And what's nice about the Houtman, admittedly, is that I've never looked down at a Houtman and been confused about how it folds or how it turns. The Studer can be somewhat confusing. I think the Houtman is a little more straightforward in terms of orientation. Again, although there is more sewing, we typically do that with a 2-0 VIPO or a 2-0 polysword. But this idea of folding the bowel, it comes back to some physics and Laplace's law, which dictates that the transmural pressure and the wall tension are proportionate to the radius of that segment. So if we detuberize the segment, we increase the radius exponentially. And then that in turn changes the transmural pressure, the volume it's able to accept, and the tension on the walls itself. So there's multiple folding options available with both the Houtman and the Studer. So once you actually create the neobladder, then you also have to turn back and address what to do with the ureters. The 2 methods that typically come into play are whether to perform a Bricker or a Wallace. I will admit that we perform routinely Brickers almost exclusively. I've done a couple of Wallaces in training at Mayo Clinic, but those are typically done for non-oncologic reasons. And one of the reasons to do that in the setting of a non-cancerous cystectomy is that patients who have a positive CIS margin in your ureter, you wouldn't want to necessarily anastomose that to another healthy ureter, which could then become involved or contaminated with the CIS, or CIS could then ascend into that renal unit. When selecting patients for continent diversion, there's several factors to consider in properly selecting these patients. One of which is their kidney function. And typically we won't perform continent diversions in patients who don't have a creatinine level that is less than 2.0. So if they're over 2.0 or a GFR less than 40, they're typically not good candidates for a neobladder because they won't be able to clear some of the ions that are reabsorbed from the urine. There are always exceptions, and there are patients that have a creatinine greater than 2.0. In these patients, we perform a ammonium chloride loading test following their urine osmolality to determine their pH and their ability to acidify the urine. There are also patients who have prior surgeries. They may be missing bowel segments or have shortcut syndrome. Remember, in a neobladder, you have to size 55 to 60 centimeters, which can be considerable. We typically consider inflammatory bowel disease such as Crohn's to be a contraindication. Prior abdominal radiation is not a true or absolute contraindication. It's just that the complication rate can be so much dramatically higher that for a lot of patients, the risk outweighs the benefits. Also, patients in which we're going to utilize their colon, if they have any history of colorectal cancer or colonic polyps, we typically will defer and perform ileoconduit on them. Urinary function, even after we were able to perform a successful bladder, we still worry about severe incontinence. And in all of these patients, they have to be willing or have to be agreeable to be able to catheterize their orthotopic bladder for the purpose of getting out urine, or in those patients who, getting out mucus that the bowel will create, or getting out urine in case of retention. Some of the metabolic consequences that we've already touched on can be divided into several subcategories, but most of them coming back to the principles of renal physiology and reabsorption of these chemistries. These include osteomalacia, abnormal drug absorption, stones, and GI malabsorption. And again, going back to what is testable and what has come up on national exams, is typically what the chemistry will look like after each of these segments is used. And again, just driving home that ileum and colon, the most commonly used, produces a hyperchloremic hypokalemic metabolic acidosis. But why is that necessarily? Well, the most common results to be from an excess of ammonium chloride that's absorbed across the lumen of the small intestine or the large intestine in exchange for carbonic acid. And when theoretically, the larger the surface area, the higher the absorption, or the more bowel use, the higher the rate of absorption. And when looking at neobladder patients, we report that up to a third of those patients require long-term sodium bicarb therapy because of their chronic acidosis. There's several other complications to consider as well, such as strictures, kidney function impairment, which can be long-term, and recurrent or chronic infections. Sepsis and severe infectious complications can occur as well, anywhere from 3 to 13% of patients after a orthotopic or continent diversion. Last slide on the hyperchloremic acidosis. When the sodium is secreted in exchange for hydrogen and bicarb is secreted in exchange for chloride, this means that ammonia, ammonium, hydrogen, and chloride are reabsorbed in the presence of urine, and this leads to chronic acid load in the setting of ileo or colonic tissue being used. Typically, when we describe a metabolic acidosis, there's different definitions for different centers, and it certainly varies among clinical practice, but the threshold is typically less than 21, most commonly. Metabolic consequences can be very prevalent following this. Seen here at the bottom, up to a third of patients can have severe acidosis, which requires correction. And then again, showing that patients with orthotopic neobladders have a higher likelihood of having acidosis as compared to patients who have a conduit, which is only about 17.2. Another complication which occurs using the distal ileum or the colon is a low vitamin B level. And this is because vitamin B is absorbed in the distal small bowel or the distal ileum. And for these patients, some of them can require lifelong vitamin B supplementation. Long-term though, at least at 5 years, we still appreciate that the acidosis that is expected and occurs post-operatively within the first 90 days, this can still be prevalent in up to 30% of those patients. So this is certainly an issue that we counsel patients on and make sure they are consented for before going to the operating room. Renal function changes as well are not insignificant. And again, this has to do with how creatinine is measured, how GFR is measured, and how the urine is reabsorbed through these bowel segments. We typically find the lowest deterioration to be in patients that have an ileal conduit where urine is passively excreted through the conduit into an external appliance. We have not found that refluxing versus non-refluxing reimplantation is important, but overall we found that about 30% of patients had a decrease in GFR long term. However, it is important to keep in mind and to counsel patients that obstruction is thought to be the leading cause of decreased renal function. these patients, which is why it's so important during surveillance to screen them for hydro and to ensure that there's no functional obstruction which can be corrected. In these patients that do have an acidosis, we typically begin treatment with oral sodium bicarb, 1 to 2 grams BID, which is effective in most cases. We also ask them to stay very hydrated. In patients who cannot afford or cannot tolerate sodium bicarb, and also sodium citrate, but patients typically hate this. It tastes very poorly. And there are other options as well. Potassium can be supplemented when leakiness occurs during the correction of acidosis. And we should also be considering calcium supplements. These patients, because of the chronic acidosis, can lead to breakdown of the bone. And a typical test taking question is a patient with a ileocondylar or a neobladder has osteoporosis. What is the plan of action? And it's really to correct the underlying acidosis, which is what's contributing to the loss of calcium and the loss of bone infrastructure. Stone formation is twofold and somewhat compounding in these patients. Number one, the hyperchloremia results in calcium phosphate and calcium oxalate stone formation. There's also decreased urinary citrate levels, which contributes to stone formation as well. And overall, there's higher levels of urinary phosphate, sulfate, and magnesium in alkaline urine. We find that stones are more of a problem in patients that have urinary stasis, so patients with neobladders or continent catheterizable pouches, or patients who have foreign bodies that are present within those. So if you have an ileoconduit and a staple line or permanent suture, those patients are at risk for forming stones. If you have a pouch with a staple line, those patients are also doubly at risk for forming stones. And these can be very troublesome. And what's even more troublesome is that these are not typically associated with improvements with just oral therapy. They typically require a surgery, whether endoscopic or open. Similarly, these stones that form can harbor bacteria, which can produce either the struvite or carbonate apatite stones long term. This is a great picture in a CT scan here in our top left image of a patient of Dr. Gilbert's that had a very large stone burden following a neobladder. And then patient, I believe this patient was managed in an open fashion, but during the cystoscopy, you can see here, this is the stone on the outside, nice and smooth. And then once it was moved out of the way, we could identify a staple, which likely served as the original nidus for stone formation. Once the stones are taken out, you can appreciate these are several centimeters in size. I had a patient, Dr. Gilbert, that we excised a stone from his Studer, and the stone was about the size of a baseball. And so these can become considerably large, lead to chronic infections, chronic pain, and ultimately need to be addressed. One method for avoiding these staple lines present is total excision. And Dr. Adai and colleagues, I'm not sure if you were performing the bowel segment anastomoses and bowel segment excisions, if you're using staplers or not, but even if you're using a permanent suture, if those sutures are in the lumen of the GU tract, they're still at risk. One of the methods that we've used here in the US, because staplers are so often used, is that we excise the staple line, cut it off completely, and we perform a Parker-Kerr inversion technique, which is really oversewing the staple line, oversewing this opening in the bowel where the staple line was, so there's no permanent sutures or permanent objects within the GU tract for urine to come in contact with. So we've gone over several complications in terms of the GU tract, but there can also be significant GI issues after the surgery. We touched on vitamin B12, but also there's a significant role for bile salts to be reabsorbed in the distal ileum. And diarrhea can be extremely common after this surgery. And the reason being is that these bile salts can typically require or create a secretory diarrhea, meaning that water is pumped into the colon, and these bile salts, because these bile salts are not being reabsorbed into the distal ileum. One of the fixes for that is to prescribe cholestyramine, which is a resin that binds the bile salts. Once the bile salts are bound, there is less of a secretory function of the colon to secrete water into the lumen. And if the cholestyramine does not improve, you can certainly use an anti-motility agent such as loperamide in cases that do not respond. Urinary tract infections are especially predominant, and these can occur anywhere between 5 to 30%, depending on the series that you analyze. What is a particular problem here in the US is that patients will go to an emergency room or an urgent care clinic or the primary care doctors, and they will typically send off a urine culture and a urinalysis. And in these patients with bowel that's associated with their GU tract or their GU tract, they will always be colonized, meaning that their culture will always be positive. And so it's very important in these patients to distinguish the difference between bacteriuria, the asymptomatic bacteriuria in a conduit or a fecal bladder, versus patients who have an active infection requiring IV or oral antibiotics, ascending pyelo, or pouchitis. So it's very important for these patients to counsel them and ask them how exactly did they find out about their infection, what was their situation, or what were their complaints at the time that their infection was diagnosed. And this is more of what we had just touched on in terms of the bacteria that are identified are most commonly Enterococcus, most commonly isolated from cultures, followed by Klebsiella and E. coli. And what can be particularly problemsome for these patients is that postoperatively they have received antibiotics, so bacteria that may flourish may be antibiotic resistant, as well as these foreign objects that are in the GI and GU tract, and so fungal infections are also predominant. Although I mentioned asymptomatic bacteriuria and that not all patients with bacteria in their urine need to be treated, it is important to know that patients with a Proteus, Klebsiella, or Pseudomonas culture do need to be treated even when they're asymptomatic. And so in patients that do have recurrent infections, Dr. Gilbert likes to cite this. Step 1 is to rule out a stricture, and number 2 is to rule out a stricture. Rule out anything that could be causing stasis of urine or inadequate drainage of the kidneys. There are certain patients that have recurrent infections that respond very well to oral antibiotic therapies. And for those patients, we'll typically prescribe them antibiotics to hang on to so that they can self-start therapy if this were to recur. And then in patients that really are having a difficult time and just seem to always be on antibiotics, you can prescribe antibiotic prophylaxis. An interesting and relatively recent alternative to this is methenamine hippurate, which can be used for prophylaxis. Now, there are many nuances to prescribing this medication. It is relatively new, but a randomized control trial did show a benefit for decreasing UTIs over a 12-month period. Admittedly, this study was not done in patients with ileal conduits, but we have seen success and have used this in patients. And what this typically does is sterilize the urine. It does need to be taken with vitamin C for loading purposes, and then patients need to be drinking adequate water to actually secrete this into the GU tract. Looking more distally to the stoma and the appliance, again, I realize ileal conduits are not necessarily as widely utilized in Ghana, but when we perform these here, we always counsel patients on the possibility of having stomal complications in peristomal hernia. The incidence rates can vary anywhere between 5 to 65%. Looking at several studies, they had suggested that approximately 17% had peristomal hernias. And the risk factors for these are very well known, including women, higher BMI, lower pre-op albumin, and previous abdominal surgery. Really anything that could compromise the integrity of the support structures or put a patient at risk for a regular hernia, also puts them at risk for a peristomal hernia. There are several techniques that are used, including the keyhole and sugar baker technique. Some GU surgeons will perform this, but typically it's a abdominal GI surgeon that specializes in hernias. Mesh has also been prophylactically used in these patients. There have been 4 small studies that have shown promise. There's a 50% reduction in peristomal hernias, and overall a low, sorry, hold on. My keyboard's acting up. Overall, a low incidence of complications. Some of the functional outcomes and patient-centered outcomes are important to note, especially when comparing the ileal conduit and the fecal bladder. And when analyzing these patients on long-term follow-up, the overall picture is patients who have an older age, who have longer follow-up and fewer complications, typically had a better adaptation postoperatively or had coped better postoperatively than patients who have received an ileum conduit. But there are still significant challenges to these patients postoperatively. Up to 70% of these patients have issues receiving just general care. And in patients who have a stoma or a fecal bladder can have troublesome time finding appropriate catheter care. They can't see their appliance. They have difficulty flushing their tubes or stents. And something else I'll draw attention to is a lot of these patients have postoperative mood issues, including difficulty managing my emotions, difficulty sleeping, or depression. And excuse me while I find the data here, but for the depression, likelihood in these patients is quite significant. And truthfully, we've also had to screen some of our patients, for their suicidal possibilities postoperatively, because it's going to be a major hit to their self-image, and it's a very long recovery process. But this is looking at some of the bladder cancer index tools that Dr. Gilbert had used, basically showing some of the differences between conduits and fecal bladders in terms of self-image and bladder cancer index, meaning that patients with a neobladder tend to have a better return to their normal functional status as compared to conduits. But 12 months later, 16 months later, these curves tended to level off and be very comparable. So with that, I wanted to say thank you so much. And I would really love to field any questions or go over any of these techniques. And thank you to Dr. Adai and Ashley for having me. And yeah, I can't wait to get back out there. And I'm so grateful for our time there at CAP.
Great delivery. And thank you, Dr. Carl, for such an excellent presentation. I think at this stage, we would like to open the floor for questions from participants. Before somebody comes up with a question, Carl?
Yes, sir.
I would like to know how we can prevent calculi or stones in the pouch.
Right. Well, and I was going to ask you about that. Are you at CAP utilizing any staplers or permanent sutures when you create a pouch or a bowel diversion?
Okay, so we don't use any staplers. We just use the hand sew with absorbable sutures, Velcro mostly.
Okay. And is that
so for the past 5 years, I've done a number of new bladders. I really haven't seen any case of bladder stone, pouch stone, but I remember there was this case done by IVU. He had a bladder dystrophy, so a new bladder was reconstructed for her after the bladder plate was removed. She's about 28 now. We had to remove a very big stone from the pouch. And at a point, he had a mitrophanov actually. It got stenosed. The catheterizable stents got stenosed. So after we removed the stone, we left her with a suprapubic catheter. So that was the only one or first case of a pouch stone that I have seen. But because this was done like almost like 20 years ago, so I don't know going forward what our outcomes will be in terms of stone formation. But what is instructive is that we keep our patients with urinary diversion on potassium citrate. I don't know whether, because we've seen that it reduces mucus production, and we don't know whether in the long term it will be useful for prevention of stones in the pouch.
Right, right. I think that here in the U.S., one of the biggest issues now, I'll go back to that image with the stones. One of the biggest issues that I think contributes to stone formation here in the U.S. is the use of staplers. And the reason being is that staplers are fired across the bowel and then either incompletely excised or not excised, which is an issue. And so here in the States, I think that's one of the biggest problems. And there's a great quote that I like about staplers. When they first started to come out here in the US, a colorectal surgeon told me that a stapler will make a good surgeon great and a bad surgeon worse. And so what that means is that utilizing these, they're not necessarily benign. And total excision, especially in a pouch or a needlebladder of the staple lines and these permanent objects, is critical. Now, I think if you're closing the needlebladders and pouches in one layer with absorbable suture, I think that is perfect. The only optimization of that patient I can really think of is ensuring that you don't have stasis of urine and ensure she has adequate drainage of the pouch. And it sounds like she had stonal stenosis, which can certainly contribute. And it makes you question if, when she was catheterizing for possibly the 8 to 10 years prior to presentation to you, if she was emptying it completely. But I don't think anything outside of what we've already discussed could have been improved on in that patient. And also, I'll also say, as a profession, I think if she had a needlebladder done, how long ago? 10 to 18 years ago? Or a pouch done?
Come again, Carl?
How long ago was her pouch, or how long did she have that pouch for?
Okay, so this was done by an IVU team led by Schneck around 2005. So
yeah,
we are about 18 years, but I removed the stone from her pouch like about 4 or 5 years ago.
Okay.
So you are looking at about 10, 12 years.
Yeah.
Yeah.
The only reason I'm asking is I think 10 to 12 years with a new bladder without any big complications is pretty darn good. I think I think that pouch that she has was created by humans. It wasn't necessarily the one that God had given her, right? And she's doing very well with it. I think having some stones, in 10 years time is fantastic. Just in the grand scheme of things, in the big picture. I did get a question from Solomon Dino. How do we treat your ureteric stricture and stenosis at the implant site? I think this is a great question. So let me close the chat real quick, and I'll go. Let me go to this picture of Bricker and Wallace. Got to find it first. So the question was, how do we decrease the stricture rate and stenosis rate? So I think it's going to be very, very difficult to perform a randomized control trial or a proper study to look at this next point I'm going to bring up. But one of the questions that comes up is if you run your anastomosis in a continuous running fashion or if you interrupt them. And I will admit that I'm a part of the converted, where I trained at Mayo. We would run our anastomosis. It's significantly faster. I thought it produced a little bit lower of a leak rate. And then at Moffitt, we tend to interrupt them. Not all the surgeons, but many. And what I will say to that, and I'll find one more picture. Yeah, this is a great picture. And so what we're looking at here is the ureter splayed wide open. I will say that the technique that we utilize to interrupt the ureters, I feel like helps us visualize the ureteral implant site and the reimplant site. It helps us to cut back further on the ureter where the blood supply is going to be most viable. And so the question about how do you decrease the stricture rate, I think the most important thing is to perform tension-free, use a segment of the ureter that is well vascularized, which ultimately means cutting back far enough. And then taking your time. And I say that because the ureteral reimplantation utilizing a interrupted fashion takes longer. I mean, it noticeably takes me longer than to run a suture. But nothing takes longer than having to take those patients back to the operating room to reimplant, because it's always a very hostile abdomen. It's a nightmare of a surgery. It's not satisfying. And so I always keep that in mind during this portion of the surgery when it's taking longer than I think it should. I always think to myself that it would take longer if we had to reimplant this 3 to 4 years from now, or God forbid, 6 to 8 months from now. So that was one question. Let me see the chat. There's also, what are considerations for urinary diversion for kidney transplant patients? Great question. It really depends on the setting. So if you had a kidney transplant patient who has an indwelling kidney, so I guess that could go 2 ways. It could be an indwelling kidney transplant, someone who has a kidney transplant already in place that requires a cystectomy. We have performed a ureteral reimplant from the transplanted kidney into an ileal conduit, and the flow of urine was fine. And we've seen 2 or 3 of those at Mayo Clinic, which is a very big transplant center. Another way of asking the question or looking at that is in a patient who is going to get a transplant, are there any other considerations? And we have also made, we call them a dry conduit, meaning that we create an ileal conduit so that one day when that patient gets a transplant, they can take the ureter of the transplant and directly implant it into the existing conduit. We call it a dry conduit because typically those patients who are transplant candidates that don't have a transplanted kidney yet, they don't make urine, or they don't have the G organs, which is why they need a transplant. But we've seen both and we've had success with both. Stricture treatment after conduit. Okay, so sorry, this is a clarification. So it depends on the degree of the stricture. I think that strictures can be extremely troublesome for these patients for many reasons. One, because it can produce hydro and it can decrease the renal function. These patients can also have severe flank pain. They can have recurrent infections. So I think the immediate action is typically a percutaneous nephrostomy tube. The reason I say that is because it also increases your options for therapeutic management of the stricture. Meaning that you can attempt to place a stent, you can attempt to balloon dilate the anastomosis. But I think the success rate of that is relatively low, probably somewhere between 20 to 40% on a good day. It does not mean that's not worth trying. But typically, if a patient fails balloon dilation, they fail stent placement and expansion of the anastomosis, they typically require an open reimplant into the neobladder or the conduit, which is, again, a very troublesome surgery. It can be very difficult, fraught with complications. The patients have a slow recovery, and you're entering a very hostile abdomen. And believe it or not, there's a very high risk to the contralateral ureter at the time of surgery. And so again, that kind of goes back to what I tell myself during these surgeries when I feel like it's taking longer or we should have been done earlier. Is nothing is worse than having to go back and reimplant or revise these connections. So I hope that answers your question.
Carl, can I make a contribution regarding the ureteric strictures post urinary diversion?
Yes.
Okay. So one of the ways in which you have an increased rate of stenosis of the urethral alia anastomosis is if you try to do non-refluxing anastomosis, it's been shown to have a high risk of stenosis.
Right.
And there's per experience, you realize that the new bladder that is reconstructed is really a very low pressure pouch with a very little risk of reflux. And so simple non-refluxing anastomosis of the ureter to the new bladder should be the way to go to limit the chances of stretcher than anastomosis side. And secondly, for those that have had refluxing, non-refluxing anastomosis, cystoscopically one can try to open up the point where the ureter is intramural, and as far as possible, and put in a stent and wait for a while, then remove the stent and see whether it doesn't heal and close again. That is one way to also solve the stretcher, apart from the dilatation and open reimplantation. Thank you very much.
Absolutely, those are great points, sir. I will to support your point about the refluxing and non-refluxing. I have never seen or done a non-refluxing anastomosis for a bowel diversion, and I think that speaks to your point that the stricture rate is lower, and we do not, as a profession, we do not feel that there's a downside to doing a non-refluxing. Sorry, there's no downside to doing a refluxing anastomosis. So I 100% agree. The comment about getting access to a ureteral reimplantation site to manage a stricture, I think it can be very, very nuanced because if a patient presents with a stricture, it can be very difficult to go retrograde through the bladder to identify the ureteral implant site and get access or get a wire up into the kidney. And every patient's different. And that's why I mentioned I typically would like to perform or put in a percutaneous tube first, so that we at least have a backup option if we're not able to get a wire up into the ureter. There was a paper that I've been trying to find forever that was published in the Gold Journal about 3 years ago that looked at a combination of balloon dilation, so endoscopic balloon dilation, and Kenalog injection into the ureteral intestinal anastomoses, and it quoted a success rate of 80 to 90%, which would be phenomenal. And I would hope that's true. I keep trying to find this darn paper, but using Kenalog is also an option. There's a question about, are there any new information on artificial bladder substitute? You know, the only thing I can say to that is the University of Southern California, they had mentioned they were performing the first bladder transplants recently. I haven't heard any updates on it or how it went, but apparently they were planning to perform the first bladder transplantation. Any other questions or anything else that I can help to clarify or get feedback on?
Hello, Carl.
Hey.
Good. I wanted to know whether is there any point in time that you have to resort to ureteral sigmoidostomy, something like Mastouk pouch?
I have not. We typically won't need to in patients that need a urinary diversion. One of the reasons why we in the US have gotten away from using sigmoid colon. I always thought it was from the risk of cancer, but it's from the chemical disturbances that can occur postoperatively. I mean, what are the situations in which the mains 2 is used? So like in what situations is a mains 2 patch used in Ghana?
Hello?
Hey, Richard, can you hear me? Or was it Roland?
Hello, Carl?
Hey,
yeah.
Roland, can you hear me?
Great. Yeah, I can hear you now.
Okay. Sorry, I was asking what patients do you typically utilize a mains 2 pouch in?
There were a few instances where we had to use this for bladder atrophy.
I see.
And also post cystectomy for radical cystectomy for bladder CA.
Right. No, we typically haven't used it here in the States. And I think that the main reasons that we've gotten away from it are twofold. One, for the chemistries in those patients are usually more intense than patients that utilize the colon and the ileum. And then we've also identified that 10 to 15 years later, they have a higher incidence of colorectal cancers. That doesn't mean that it's not a good option, especially in the hands of an experienced surgeon for those bladder exstrophy patients. I will say I had a couple of pediatric patients who had, and this is a different situation, but they had very difficult GU tumors, which are extremely rare, but they still sadly had them. And those patients received a temporary ileal conduit. And then a year or so later, after their adjuvant therapy, they received a more formal recreation, such as an Indiana pouch or a EO bladder.
Great.
Yeah. Thank you.
And Carl, we've seen 2 cases of sudden deaths in patients with urethrosigmoidostomy, i.e. the man's pouch. Patients will be doing very well. They are on potassium citrate. Either they are taking it religiously or not, but on 2 occasions, we have had 2 patients die suddenly. Do you have any experience, and can you help us explain why patients with urethrosigmoidostomy will die suddenly without really falling sick?
It's hard to say without looking into their cases and the circumstances. First of all, I'm very sorry that had happened. I know that can be very traumatic for everyone involved, especially the surgical team that's caring for the patient. But with a sudden death like that, I start to worry about the possibility of severe sepsis, and that can occur very quickly in those patients. Also, issues such as potassium and the chemical abnormalities that can occur, especially in the electrolytes, that can possibly lead to sudden cardiac death if those electrolytes are not corrected adequately.
Okay. All right. So I think we don't have Ashley on the platform yet. She initially told us she will be off for a while.
Yes, yeah. I think Ashley is enjoying the countryside of France.
That's right. So in the absence of any other questions and comments from the participants, I would like to take the opportunity to thank you very much, Kyle, and for such a wonderful presentation. You really benefited immensely from this presentation. And as you said earlier, we will be waiting for you next year. You said you'll be coming in the summer, right?
I think so. I think the plan is for August.
Wonderful, wonderful. So anyway, anyhow, we need you, we'll contact you again for another presentation.
Oh, please. I'd be happy to do it.
Wonderful. Thank you very much.
Thank you all so much.
Thank you, Carl. We are grateful. We are grateful.
Yeah, our greetings to Dr. Park.
I will send it his way.
Great. Thank you very much, and have a good day.
All right, bye-bye.